Drug is the same thing as digoxin. He had another trade name for it. This is like the generic name.
That's what they use on
Okay.
That I see now.
Okay,
Yeah,
great.
I've
Okay.
seen it.
So this is the drug for CHF, and this is the mechanism of action, how it works. This is the cardiac cell, for example. These are the pumps in the cell. So you have sodium and potassium, right? This is the ATP, sodium, potassium, ATP pump, right? This pump, you have it in all your cells, all the cells in your body. You just have to have it. You have, potassium coming in, potassium going in, sodium coming out. If you don't have this in your cells, you can't contract muscles, lots of stuff. But the digitalis inhibits this pump. So it inhibits this pump. And it's for good reasons. You're normally supposed to have sodium going out, potassium coming in. So if this digitalis stops this pump from working, you end up having you have the opposite effect, right? You have sodium staying in, potassium staying out. So more sodium in the cell, potassium out, because it inhibits that pump. When it does that, remember I said that there's another pump that also works in the cell that depends on this pump. So if this pump doesn't work, this pump doesn't work. So this is the primary active pump. This is more like a passive pump because it depends on this pump. So if this pump is screwed up, guess what will happen to this pump?
It doesn't work.
So this is the normal pump, right? Sodium should be in, calcium should go out, right? So when you have this pump being screwed up, this pump isn't working, what's going to happen? The reverse action. Calcium will stay in, sodium will go out, right? This is a good thing for the heart cell that's weak. Because guess what? You need calcium to contract muscle. Remember that from your physiology, So if you have calcium staying and you have a lot more calcium staying and being trapped in the cell here, in your cardiac cell, this is what causes the increased contractility that you see with digitalis. It's a good thing. So the fact that it inhibits the sodium, potassium, ATPase pump, and then causes this one to not work, and you have a reverse action, you have more calcium staying in the cell. Basically, they'll call it calcium sequestration. It stays in the cell, and you have more contractility. That's what you need, because your heart muscles start to contract, and in CHF, your heart muscles don't contract, right? You're not able to, like CHF is a combination of both right and left heart failure, right? So when you do this, your left heart is able to pump blood out more, your right heart is able to function, so you don't have you're basically treating the CHF with this increased contractility. But now the downside of this is, because increased contraction, is always, your body has to compensate for that. So the way it will compensate is by decreasing heart rate. So these are the big things for digitalis that you need to know on the test that they'll ask, if they'll ask anything about it. They'll probably never ask you this. All of this stuff is all physiology that I know because I'm in med school, they teach this stuff that they'll ask me that, but they won't ask you that. You just know the mechanism of action is. That way you don't have to cram that in. Oh, increased contractility. Okay, so what? Increased contractility.
But that's a good thing, right?
But you have to know that in order to get contractility.
Right.
Okay.
So you could just probably cram this, but if you know why it increases, calcium is increased in the cell, and calcium causes muscles to contract, right? You can't. People that are dead, like this is the typical example of someone who's dead, and they have the rigor mortis. Why do they have rigor mortis? Calcium is leaked out of the muscle cells, and so they're stiff. So if you don't have calcium, you have no contraction whatsoever. So that's why this, if you think of it in that sense, that this is how this pump works, and you get this is what you get. And you basically treat your CHF. Now, the side effects of this could be hyper or hypokalemia, with increased potassium or low potassium. You could do it either or. And as he said, you can, yes.
What chemical leaks into the blood for rigor mortis?
I was just explaining that calcium. It's an ion, right? Calcium causes contraction, right? I was basically trying to explain that if you don't have calcium from your physiology, you can't contract muscles. You see right there. First of all, if you have no calcium, you have no sodium in your cells, you're gone. If you have no sodium in your cells, you're going to have a problem. If you have no calcium, you can't contract, you can't lift your muscles, you can't do work. Period. If you're dead, You have no calcium is leaking out of the cells because all your cell functions are shut down. So calcium leaks out, and that's what causes the rigor mortis, like the stiff muscles. They're not contracting. I was just trying to explain. So don't. That's not important. Okay, so we have that, right?
So then why do we have hypo or hypo?
This is
hyperkalemia.
Yeah, because of
the pump. It's inhibited, right?
But if it doesn't work, then wouldn't it be only one?
They say it should, because there's nothing that's perfect in nature. You always have to think about the fact that in medicine nothing is absolute. So it's supposed to do this. It'll inhibit it, but obviously you still have some, something leaking in and out.
But I would think they would have hyperkalemia because it's not.
That's what she's trying to explain.
And not.
You would have both hyper and hypo in the sense that you probably have, as he said, there's more hyperkalemia than hypo. There's definitely more of this. But you have both because in medicine nothing's absolute. You don't always, you're supposed to inhibit the pumps, but remember this is like cellular level. It's not one pump, it's like millions. And sometimes you can't always have a perfect. So you have some ions leaking in and out, and then you upsetting the balance. And then obviously you're giving this person like a synthetic drug, right? Digitalis is like synthetic. It comes out from you're giving medication to do all of this stuff. So obviously you have one of these happening. So if you have this, now we're going to talk about ECG changes. Important. If you brought it up, right? ECG changes for hyperkalemia. This is your PQ. Wait, hold on.
Is this for hyper?
P U R S T. This is your normal sinus reading, right? So when you have hyperkalemia, what do we have? We have a peaked T wave. So this is normal, but then for hyperkalemia you're going to have this. So they might ask you a question, give you a whole scenario of someone on digitalis. Most likely they'll give you a question of someone on digitalis and then say that they have tall T waves or peaked waves, and they'll be, what's that? You should be thinking hyperkalemia with a peaked T wave. They might not show you an ECG. They'll just say
ventricles are not.
Okay, let me do that. Now you're making me talk ECG. P is atrial contraction.
Yeah.
So when you have your atrium contracting, on an ECG wave, it reads as a P. This is the wave.
That's the atrium, and QR is the ventricle.
Right.
But then they ripolarization
Is the T wave.
is the T.
Right.
So it doesn't ripolarize. So it is
Hyper. This is ripolarization. This is your cardiac. In your cardiac muscles, this is your ventricular depolarization. You have this. Oh, sorry. Remember this from physiology?
Yeah.
Okay. Phase 0, phase 1. Sorry. Phase 0, 1, 2, 3. What's happening in phase 0? By the way, this is only seen in cardiac cells, okay? You never see this in muscle cells. What you see in muscle cells are the regular, phase 0, 1, 2. Why? Because this is a plateau. In cardiac cells, you only have a plateau due to calcium influx, causing the contraction as well. So that's why you have the plateau in cardiac cells. So in cardiac cells, this is your depolarization. This is your plateau. This is your ST segment on ECG. You have to correlate the two. And your third, this part is your repolarization. This is when you have potassium going out of the cell. Here you have sodium going in to cause an action potential. No action potential, no cardiac contractility, no muscle, nothing contracting. Right?
No, I might not be able to read it on the computer, but I can hear you.
Oh, okay.
At least we'll have the audio, I guess.
So, so what you were saying, the repolarization here, potassium efflux going out of the cell, is your T wave on ECG. So basically, you're doing what's happening in the cell, you're putting it on ECG, and interpreting it's the same thing. So your P wave is your atrial contraction. Your TRS is your ventricles contracting or depolarizing. And your T wave is repolarization, going back to -0, whatever it is, to start the cycle all over again, to depolarize. This is the cycle of muscle contraction. You don't have this, you can't contract muscle, right? This is very biochemical, like in very chemical level. So what you were asking about the T waves, when it's that high, you have a lot of potassium efflux. So that's why you have a peaked T wave in hyperkalemia. For hypo would be the exact opposite, right?
Wait, before you do that, you said, okay, hyperkalemia. I'm looking at phase 3. I see K going out,
Yeah, here.
right? Okay, so I'm seeing K going, that would be out of the cell.
That's out of the cell.
So
this is
going
why
into the
would
blood.
hyperkalemia.
No, but this is hyperkalemia. This is for digitalis, remember?
So
Right.
would that
She was
be-
actually asking me